So first we'll do some introductions.
Sure.
We'll cover Higgy a little bit. We'll take a look at the study overview, then we'll have some discussion with the panelists, and then we'll do some questions. So I'm going to let the panelists introduce themselves, starting with Sangeeta.
Hi everyone, thank you for coming here. I'm a nurse and I'm also a computer engineer. I've worked in gamification as well as in patient behavior change and worked with cardiac patients.
Can you say a little bit about HelpSee?
Sure. I'm the founder and CEO of HelpSee, and HelpSee focuses on supportive care and symptom management, so working with the patients on their health conditions and helping them to find the referrals, as well as to work with those practitioners to achieve the goal that they want.
Excellent, thank you. Geri.
I'm Geri Baumblatt. I'm the Executive Director of Patient Engagement at EMI, where we make multimedia, interactive patient education and engagement programs and interactive calls. So I'm more on the patient engagement side than the gamification side, but we've done a lot of work in chronic conditions like hypertension. So,
Dr. K.
Thanks, Ryan. I'm Khan Siddiqui. I'm Chief Technology Officer and Chief Medical Officer of Higgy. I started my career as a software engineer, same as Sangeeta did. I became a physician as a HD radiologist. Before Higgy, I was at Microsoft running the platform engineering team for the Health Solutions Group. So one of the early team members and founders of Higgy.
And my name is Ryan Wynia. I'm the Vice President of Design and Product Science at Higgy also. So I'm going to turn it over to Dr. K for a little bit of overview of Higgy and then the study.
Sure. So Higgy is a cloud-based community health engagement platform, really designed to help patients engage better with their healthcare. It doesn't make a difference what the care program is or chronic condition is. We really become the engagement layer on top of any program that is out there. One of the unique things about us is that we have a network of connected kiosks, health stations, self-service health stations that we put in retail pharmacies nationwide. We founded around 2012 timeframe. We are now in 10,800 retail pharmacies nationwide, going to a much larger number in the next few months. We have about 35 million people have used the platform to date. We also connect to pretty much every popular wearable device that is out there and home monitoring device. People have tracked about 120 million miles on the platform to date. So our footprint really is we are within 5 miles of 75% of US population. And the reason we took that approach as part of our engagement strategy is that our whole belief was that it's very hard for patients or consumers to build new habits, but it's much easier to tie to existing habits. A typical adult goes to a retail pharmacy about 1.3 times a week, whereas a typical adult goes to a physician maybe every other year, or if you are chronically ill, maybe 3 times a year. So the retail location ends up becoming a much higher touch point for consumers and patients. You have to go buy your groceries and stuff, so it's part of that whole strategy. So the whole idea was that can we engage with them where they're normally going on a weekly basis and enforce that habit. So that's what we've been able to do now. 55% of patients who use Higgy actually use before they go shop. So now we can influence the shopping behavior based on what they're seeing, what their outcomes are. So we've been able to really scale fast because of having that interesting network of kiosks. What we also do is, as part of that engagement strategy, is apply game dynamics. We follow hide and seek principles. Hide and seek has been studied. All these older games have been studied a lot. One thing I learned in Microsoft was that when Xbox and teams think of a game, they don't think of game design as a video game. They go back and look at what games have survived millennia, survived cultural boundaries, survived gender boundaries, age boundaries, so that the games are more popular and everybody plays in it. And they try to understand psychology behind each of those games. So it's chess, snake and ladders, it's solitaire, things like that. Those are the ones that actually help you understand why are these games engaging, why are people still playing them. So hide and seek is interesting. It has 3 components to it. It's a simple narrative, meaning you hide, you find. That's all you do. And Higgy, it's all about being more active and knowing your numbers. So that's the only thing you do and then to get your scores going up. Next is progressive mastery. So in hide and seek, if you're hiding in this room, it gets pretty hard after a little while to find a place to hide. And if you do, then the person looking for you will have a hard time finding you too. Plus, it has an over time dynamic of progressive mastery. So when you're a young kid, you'll have a lot of fun hiding in this room, but for us to hide now, we could probably hide entire Stanford campus, or we can go the whole Bay Area and play in hide and seek like that. So it can become over time much more complex game. So it has that in-game progressive mastery and over time progressive mastery. And the last one really is connectedness. So you're hiding against somebody who's trying to find you, but you're also kind of competing and cooperating with the people you're hiding with. So if we all go hide in one corner, it defeats the purpose, everybody gets fined. So you have to cooperate with each other to be able to play the game. So the same thing in our game dynamics, we bring those in. So your Higgy score can go up to a certain extent, and after that, you have your friend's score, it starts to influence your score to be able to go up. So you really have to work with them to get yourself to the next level. So we have built those dynamics in the whole program. And then to enhance, I really see the game dynamics in Higgy really is a part of the connectedness or the social aspect of it. So it's really bring the social influence as a game dynamic strategy into Higgy. The other thing we focus really on is social influence. There's a lot of work done by Bob Cialdini since the 80s on talking about what are the factors of influence, how does the individual get influenced. And then recently, Agnes Tybee at MIT actually took all the research done since the 80s, 70s on influence and has mapped out social aspects of the influence. And he's identified 7 different components of it: social competition, cooperation, recognition, facilitation, comparison, learning, and then normative influence. Normative influence is what we're trying to get to, is when it becomes a norm to do certain things. So like smoking used to be a norm, so everybody smoked. Now it's not a norm, so if you try to do it, you look like the idiot standing outside the building trying to smoke, especially in Chicago in minus 15 degrees. It becomes really hard to go do those kind of things. So that's what we're trying to get to on a normative influence point of view. So we really try to employ these aspects of social influence in technology as part of the experience of the user. Our game dynamics and challenge really focuses on 2 of them, which is social competition and social recognition. Those are the ones that have been shown in research that increase engagement. So what we did was we thought this study was done late in the last year, where we wanted to look at what has been happening in the network of our stations and our user base over the last 3 years. So from September 2012 to April 2015, we looked at de-identified data to see what has happened and what the findings are for us. So it's a long-term kind of evaluation of what is happening. So about 9,700 kiosks were deployed during that time period. So remember, we were putting more stations too, so it was not like on day 1 there were 9,700. Day 1 it was probably 1. About 2 million patients created accounts on the platform during that time period, and 158,000, almost 159,000 patients, hypertensive patients that we looked at who had hypertension, had longitudinally engaged on the platform, which is a pretty high number. The largest study before this was 60,000 patients ever done in hypertension, so this ended up being 3 times larger than the previous larger study done in this space. So we looked at level of engagement in terms of how often they engage on the platform, either web, mobile, or on the station side of things. We also looked at overall change from their first engagement to the last engagement. It can be a varying engagement based on what is happening. We actually went a conservative route. Probably should have looked at every single element of it, or segmented quarterly or even monthly basis to see how the blood pressure is moving. But we decided to do a conservative approach. When you started at Higgy, if you were hypertensive, what happened to you at the end of your experience when we were doing the analysis. So other thing is, if you all know what are the difficult audiences to engage with, usually, and everybody talks about elderly, talks about males, really hard to engage. Usually any digital health platform has more female engagement. Well, we're seeing something very interesting. So our mean age of the population was 49. So it's much on the higher side. 58% were males and 42 females. In my days in Microsoft and Microsoft Health Vault and PHR, 75% of users used to be female. So it's completely opposite of what we are seeing, much higher male engagement. And almost half are obese. So it's really the sick population is interacting with our platform. If you look at typical activity device data and what kind of population it is usually normal, more active individuals that are using those platforms. So we are seeing completely opposite of what everybody else is seeing on the wearable side of things. So what we really found was that there was a significantly statistical difference between people who logged in on a regular basis across the platforms. The more you logged in, the more your mean arterial pressure dropped. This map shows all the zip codes that we are in. Larger circle means number of population that is in that zip code that is interacting with Higgy, and deeper the green means the more drop you had on your mean arterial pressure drop, and the red means we went in the wrong direction. As you can see, pretty much everybody improved their blood pressure. The interesting finding here is that if you look at Florida and the Northeast, has a way higher density in those locations, and these correlate with two retailers, retail pharmacies that actually have a cardiovascular awareness program in the store. So they label foods which are healthier for you from cardiovascular point of view. They have dietitians and nutritionists that actually can guide you and tell you what is good for you, and they actually promote a lot. So you can look at the influence retail pharmacy and retail grocery has in people's health behavior is very significant. You can see in the map, it's so obvious how much more interaction we are seeing in those two locations with those two retailers. Here's some more data. If you look at people who interacted with us on a regular basis, so if you logged in at least 5 times or more, 84% of patients dropped their blood pressure. If you logged in at least 3 times a month, 83% of those patients actually went from hypertensive to non-hypertensive. Here's showing in a different way, similar thing. On the x-axis is logins per month, and on the y-axis is number of your blood pressure drop. So pretty much across the board drop, but more you engage in the platform, the better your blood pressure was. So again, we were not the cause of it. We were not telling them what to do. We were the measuring tool that measuring what they were already doing, motivating them to go do something about it. So were they going to the doctor doing something else? Were they not taking the medication, now starting to do it? We were not doing any medication adherence. This was just making them aware of the numbers and then just creating incentive of measuring the blood pressure again and again. It was purely that, no other treatment thing that we influenced on our side of things. People who participated in our challenges dropped their blood pressure more than those who didn't. People who were, so we are like a Twitter, so you can follow others on Higgy and they can follow you. The people who had followed others have significantly more drop in blood pressure than those who didn't follow others. It's really what our goal really was, to provide access, awareness, and incentives to help patients be aware of what their blood pressure is, and then incentivize them, make it easy for them to do it on a repeated basis and create a positive impact. So that's really what our goal of the study was.
Go back. Yeah, there we go. Excellent. Thank you, Dr. K. Sangeeta, let's start with you on your thoughts in kind of comparison and how it aligns or what it brings to mind in regards to your experience.
Working as... Hello?
There you go.
Okay, great. So working as a nurse with this population, both low income as well as what we see in the healthcare setting, hypertension is a chronic disease. Which means that it's very different from an acute problem. So if I had so the motivation is a huge challenge, which means if I had an ear infection and I had to take antibiotics for 5 days, I would be motivated to take that and finish it. Versus for hypertension, you need to take medications for the rest of your life. You need to work on diet and lifestyle change for the rest of your life, which is very difficult to do and to continue to stay motivated. So what we typically see is that it's very difficult for people to work on their health, to be compliant with medications, and to work on addressing their hypertension with all the modalities that are available. So the compliance and behavior is low. The second aspect of this is also, if it was something like pain, where if I have arthritis and I'm having a lot of pain, my body is giving me signals, right? So it's telling me, okay, you cannot really function unless you address this. Versus in hypertension, it's a silent disease. So I don't really feel the impact of it on a day-to-day basis. So it's not a problem that comes to the forefront unless it becomes a big, severe issue and you start having renal failures and a lot of other impact on the body. So those are, I think, some special challenges working with this population where hypertension has been historically very, very difficult to manage and very low compliance in this area. So this has been very interesting and exciting to see gamification and healthcare principles being applied here. And the way I look at it is that it's been very well thought of, and it's being applied well to the population to see such a huge impact. Other one quick point I wanted to bring up is with low socioeconomic status population. I mean, even in general, when you think about us, we are very busy day to day. There's a lot that we have to take care of, and you might be thinking about your kids' game coming up, or this big report at work, or you got to go fix the car, whatever. Those are the things that are in the priority at the top of my mind, right? If you think of low-income population, their challenges are 100x more amplified because they have a lot more issues to think about. They don't know if they're going to have food to sustain for all the meals, whether they can pay for their kids' education. They are working much longer, and they have very low awareness of their own body, which again results in them this being at the very bottom of the priority, or not even thinking about their health or the impact of this on their health. So in low-income populations, it's actually very, very difficult to control hypertension. So having a solution where it can engage the population and understand them seems really good to me.
Excellent. Thank you. Geri, your initial thoughts from your background on the patient experience and patient engagement.
Yeah, so I think, again, really exciting because you start to see, I think one of the things that was interesting in reading through the study is you were mentioning how, because it's almost impossible to have a control group in this setting, is that what you don't know is are you finding that it's already the most motivated people who are choosing to engage with this, which is kind of interesting. And I start to think, well, is there more we can do both for that population and for the group that's not jumping in to,
exactly right.
To use Higgy, to really kind of address what Sangeeta is talking about, which is this is a silent condition and people don't understand the trajectory of the disease. And so what we see when we have like a 15-minute program about hypertension, and we've had like thousands of people view that. And when I look through the patient comments, I do see them saying that they have very specific new understandings. So whether they're a new patient or somebody who's lived with hypertension for years, they're saying, well, I've had this condition for many years and no one's ever explained to me what the numbers meant. Nobody ever explained to me what blood pressure was actually doing to my body, let alone that over time it might affect my kidneys. And we actually tell them things like, well, so the worst case scenario is, the more you control this, the more you stave off these other future issues, which are much more serious. And I think if you just tell people over time, you're going to have problems with your kidneys, they don't really know what that means. But we go a little further and we say, you may need dialysis, you may even need a transplant. And I don't think it's about scaring people, but building that health literacy level and understanding about what their condition even is, and even how to do some of the things that you're asking them to do. Because we really try and not just say, okay, you need to cut salt. Well, what does that mean? I mean, I asked my husband, who has like a PhD in physics, and he's like, take the salt shaker off the table? And it's like, no, not so much. You can leave the salt shaker on the table probably. It's like stop drinking soda, stop eating fast food, stop using sauces, all the like hidden salt. And again, what we see from the patients who go through our programs is saying very specific things. Well, okay, I love diet soda, but I get it. I have to cut it out. We even see people saying really specific things like, okay, I'm going to be better about my diet, but I won't give up Peeps because I love Peeps. And it's like, but you understand that they're getting it. And I feel like if you could combine that kind of understanding with this kind of social interaction and motivation, that you could really keep people going, because there's that point where they get tired. So they might watch a program like ours and get really excited and revved up, and then they're going to hit a point where they're kind of like,
Yep.
But everybody around me, it's fast food, so eventually fast food with them. So yeah, I think that that's where you could really kind of amplify the effect you're having and reach additional populations with the gamification piece.
Absolutely.
Dr. K, do you want to weigh in on some of those comments?
Yeah, I think if you think about how people make decisions, so there's a lot of work done by Ryan and Desi in Rochester on self-determination theory. So there's a whole population that wants the autonomy to be able to do that stuff. Actually, the recent work they're showing that everybody wants autonomy. There used to be previous thought about that. Authority tells you to do something and you will go do it. But those research has been now looked at again, and really it's perceived autonomy kind of thing, right? So there is an element of, when you think about treatment adherence, right? So when you think about what are the motivators of treatment adherence, even though there's autonomous, I want to do this, I know somebody who has same disease, and that's why I'm trying to do the same thing. And then this factor of, my belief in the treatment comes into play. And then how's that influenced by the authority that's telling them? So what we are doing in Higgy is really, it's self-driven motivation, right? So there is no, in the early days, now there is, but in the early days, there was no health system or physician telling them, go do this. Now we have B2B programs where health systems are actually now enrolling patients in and putting them in. So we're actually engaging those audiences that, Geri, you were talking about, in which they're not self-motivated, but they would like somebody else to explain to them the value of it and why they should be doing that stuff. So I think that kind of plays into it. One of the things I'm learning more and more, there's a lot of evidence now showing that just awareness of your data is probably bigger motivator than anything else that is out there. And one of the recent studies we actually just presented yesterday at the AHA Hypertension Council was, we actually looked at that effect, that what is the effect of just knowing your number versus the social influence aspect of it and other aspects of it. And it was very close. It was, even though there was significantly difference in people who actually participate in social influence techniques, but those who were not doing it were very close and with the same results and improvement with their hypertension side of things. So it becomes extremely important as you're doing any kind of treatment programs and creating patient care management programs around hypertension, to how to get patients aware of their numbers on a regular basis. How do you make that habit? We know weather pretty much every day now, right? So you decide, like in the morning, do I need an umbrella or not? Or in Chicago, do I need to, what kind of overcoating I need to wear? How many layers do I need to wear? But we don't know that information about our health on a regular basis, and how do we actually make that happen? That's the biggest challenge. Once we get to that awareness, and it can't be one person doing it, it has to be everybody coming in together. The whole normative influence, it becomes norm for everybody to know what their weight is today and what is their blood pressure is today, and what is, if they're diabetic, what their glucose levels are, so that it becomes a norm and the habit kind of becomes just natural habit.
Thank you. Yeah, let's pick at a couple of those threads a little bit. One being the aspects of social influence in the game mechanics, and then the bidirectionality of patient engagement. So this study kind of captures what is inherent in the Higgy platform of really the patient engaging in their health, because they're doing it in the places where they already are. There is some element of outreach and engaging them with the challenges and things like that. But by and large, I would say it's their engagement. Geri, you're actually looking at the other side predominantly,
Right.
where providers and systems and caretakers are engaging the patient directly in their health and well-being. Can you talk a little bit about that, and maybe we can flip to that the slide
sure.
that you have, and you can use that to talk a little bit more about what Dr. K was saying, when you're raising that level of awareness in a little bit different way, from the other side, what happens?
Yeah. So we work really closely, not just with clinicians, but with patients to create the programs. So part of what we're trying to find out is like what frustrates you about having this condition, whether you've lived with it for a long time, what are the things that you've learned to do, what are the little tricks that you've learned, and what are the things that like get you down, and we really try and address those things in the program while walking people through, here's what this is, and here's what it does to your body over time. So again, kind of that like compassionate candor where we're saying, we're not trying to scare you, but we're trying to just help you understand why there's value in managing this sooner. And then what we're really trying to do is also help people with action planning and goal setting. So we walk them through all the different things they could do in very specific ways, right? Not just get rid of the salt, but how do you get rid of the salt? And not just exercise, but really telling people things like, hey, if you're obese, like a lot of the population is with hypertension, you know, 10 pounds isn't that much weight to lose for somebody who's large, and that can make a huge difference. And giving them those insights where it's about taking those baby steps and then helping them choose those baby steps. So we actually walk them through action planning and goal setting, where we're saying, we talked about all these different things you could do, quitting smoking, exercising more, maybe calling a friend to go for a walk every day to make it social again. And we actually have them choose something and then go through that process of saying, well, how confident are you that you can do this? And not really letting them off the hook till they've said, I can do this next week. So I think there's even a way that you could look at pulling that into the gamification, but people get to feel like you just told me to do all these things, but you haven't given me the resources around how to do them or how to attack this problem. So I think if you can give them that background knowledge on what they're even living with and what that lived experience is going to be, and that you get how hard it's going to be, but then break it down for them and make it easier. And again, that's where when we look at our patient comments, they really say, I actually feel like I can do this now, and I'm going to have one less glass of wine today, every day, and I like walking and swimming, so I'm going to do those more and find friends to do that. So I think if you go to the study that we did, this was at Centura Health, and this was with 6,500 patients. So I think what's interesting here is we were giving them the ME program, the multimedia program that's walking them through all those things along with the action planning and goal setting at the very end. And we found kind of a similar thing. So that first group, over 6 months, where they already had their blood pressure controlled, they did even better. So I think it's similar to what you're finding, that you can engage an engaged population even better. And then for people where they didn't know, we didn't have data, either they weren't taking their blood pressure, they didn't know, they improved. And then for that group that is uncontrolled, we saw significant improvement still as well. Not as high, though, as the controlled group. So I think, in a way, the controlled group is the low-hanging fruit, but you can still get them even better and in even a more solid place.
Yeah, thanks, Geri. That brought to mind something, Sangeeta, that you said in our prep discussion about breaking down habits in the social context. So kind of bringing Geri's point about baby steps and the successive approximation of those types of things, but then bringing that to a social context where you were talking about many times in our social settings, many times our families, that there's behaviors that we tend to do, we like to do together. Can you talk a little bit about how those two things kind of come together, how you're able to, or your thoughts on what you were saying about the way that those things could be broken down and tackled kind of systematically?
Sure. So we all are social beings, and a lot of our behaviors, we do it together. So when I'm at work, I'm eating my meal with my colleagues. We are going out to a restaurant together. When I'm at home, I'm having dinner with my family. When I'm going out to celebrate, I'm celebrating with my friends, with my community, with my neighbors. So a lot of our behavior and our activities are with the people that we love and we spend time with. So when we think of behavior change, because with hypertension, at being a chronic condition and working on diet, lifestyle, those are behavior changes, which means that if I am at home, am I going to make a salad for myself and then make a chicken for my husband and something else for my kids? It's going to be very strange. So when we think of behavior change, it's been shown with a lot of research that it's very difficult to change behavior of just one person. Behavior change starts by understanding the dynamics of the person and their social environment, and by bringing that behavior change to their immediate circle. So by bringing that behavior change to their family, to the friends, and being able to involve them. And Geri, you talked a little bit about that in terms of how do you do it, right? So as an example, I worked with two sets of populations: African American population, where we were teaching them diet and lifestyle changes, and we were giving them fresh food. And same with Latino population that had just come from Mexico and from South America. So we gave them fresh vegetables, and they would go home and they would cook it with all kinds of oils and spices and everything. And then the ones that they didn't know how to cook, they would turn that around and sell it to people because they could get the money, right? And here we are thinking, hey, we gave you fresh vegetables because food stamps doesn't cover fresh vegetables for you. But what we realize is that in this process, what we did not give them is education and awareness. So education about even what is going on in your body, which Geri just talked about, and then steps of how do you incorporate these changes. So how do you cook these food in a healthy way? And now, how do you bring it to your family? How do you make this food that's tasty and motivate your family around it? So what Dr. K covered on the different aspects of social influence and involving the community, as well as building the competition and the motivation, not just for you, but for your entire social group. So when you have competitions or you have points that you can use to do something, now you have involved your immediate circle of influence into this with you. So one example of this was we were giving away movie cards. Okay, so 2 movie tickets, and for people who lowered their blood pressure in the African American population. And what we found is that the mother wanted to gift this to her daughter for her birthday. So she involved the entire family in this because now she was cooking healthier food for herself, for her husband, and as a family they ate healthier for 2 to 3 months for them to get to that low blood pressure level and win those tickets. So for $20, we were able to make a difference, not just in life of one person, but in lives of 4 people.
Wow, that's incredible. That's really cool.
Just commenting on that, it's very well known in bariatric surgery research that when the father or somebody or the mother goes through bariatric surgery, the entire family drops their weight. Just because now the dad can't eat ice cream as much, or they skip those fast food trips, it actually affects the entire family. So that aspect of social circle becomes a huge. I mean, if you look at CDC's determinants of health, right? Healthcare, what we do as a care practitioner is only 10% of determinant of health. 15% is genetics, and rest is all behavior and social. So we can do a little bit of it, but if you don't change your social narrative about a certain topic or certain disease around wellness, and don't change the behaviors, it's very hard to move that needle. And exactly, one of the other things that some of the work at Tom McTavish at IIT Institute of Design have done in stroke and social influence, what they realize is that there is a key prominent person in a community that becomes, or in your family, that becomes a social motivator. They call it the social promoter. Or in the stroke scenario, the study they did, they're calling a stroke promoter. So it could be the pastor in somebody's church, or it could be the wife of the person who's had the stroke, or the mom, or somebody who has a stroke, or some dominant person in the community, in the neighborhood, that becomes that champion of helping everybody cope for the person who's developed the stroke. And especially in the underserved, low socioeconomic areas, that's where they did most of their work. And it's really interesting to see how that social circle actually influences those decisions. So let's say in Southside Chicago, somebody has a stroke. What happens? There's one person's income is gone. Who's going to get food prepared, things done, take care of the kids, all those aspects of it, and the whole community then comes in to help achieve those gaps that have not been developed in the life of a person, right? It's really hard. We don't think about it because we don't see those kind of effects happening in our side of things, but if you go and actually observe what actually happens when somebody has a complication of hypertension is debilitated or disabled, then it's not just them that's getting impacted, it's everybody in that community gets impacted.
Has Tom published that work yet?
Some of it is published, yes.
Okay, as I was going to say, point them in the right direction. But if you're interested in social influence in stroke, grab me afterwards and I can point you in the right direction for that, because it is really interesting work. A few questions.
Belief, yeah.
So that's what Charles Duhigg is saying in that book, is that when you do a habit with others, it becomes a belief, right? So the whole AA story behind that is that it's people like you. So it's a social comparison and this normative influence that you're creating in that community that is actually helping you. Now it's not just a habit anymore, it's not become a belief system. And the whole idea of normative influence comes from that concept of doing something in a community becomes a belief.
But I think it's really interesting because what we see, like when we do our focus groups, we talk about this all the time, is if you encourage people to join a support group or an online community, they're like, no, I don't need that. And I'm that person. I would not be like going to the group. But you can't tear them away from each other at the end of the focus group. They're all trading phone numbers, they're trading information, and you're like, this right here, that's what we asked you about. So I think it's kind of, we always talk about, is there a way, I think the shared group appointments are so successful because of that too, because you're hearing from other people and you're seeing that change is possible, and you're also not feeling alone with your condition, having that social isolation even within your social group. So I think in a way what you're doing with some of the gamification and the follows is you're kind of tricking people into joining a group,
I think we're creating choice. I mean, that's what people want. They don't want to be told, go do this. It's right, like, here are things you can do, and then let me choose what I want to do, and they'll end up choosing what you want them to do anyway, type of idea, right? So, for example, if you look at some of the intrinsic rewards. Intrinsic reward mean what makes me happy if I do something. The Power of Habit talks about that a lot, aspect of it. So if you look at in health and wellness, or especially in exercise side of things, right? So why do people, if you look at that research, there are certain determinants of intrinsic reward, right? So you want to do the exercise activity because it's fun for me, so it makes me feel happy. It makes me look good. So that's the reward. So I did it, now I look good. The next one is it makes me, more of an altruistic type of reward, that I'm actually helping somebody else as I'm doing this activity. I feel competent enough to be able to do the activity. So those, and then obviously the last one is the financial aspect of I'm actually winning something. So in Higgy, what we do then is, for the people who are interested in financial stuff, we have the challenges with prizes. You can redeem your points for things out there. Those who want to do because they're helping somebody else, we have a whole charity aspect of it. You can redeem your point for charities. Those who are doing it because it's social equity for them, so there's a whole challenge aspect of it, do it with everybody else. So, and then even for the looking good and feeling good, then we, in a reward store, we put in apparel type of stuff and things that somebody that is coming with that motivation and that intrinsic reward actually has something to go redeem and has something to go do. So you have to give those choice of a spectrum for the audience that you're targeting, and what are the interests are, what motivates them, and what are the rewards they would want to see, and then so that they can choose and interact with what they want to do.
Mm-hmm. I think when I think about it, I worked with AA population right here in Palo Alto and read the book Power of Habit. What I like to think about is, what is this person going through? So if I was in their shoes, right? For me as a nurse, if I'm suddenly put on a L&D unit, I will know what the hell to do, right? Because I'm not trained to address it. So if I'm going into something new, I'm trained and I'm given the confidence that I can handle this situation successfully. When we get diagnosed with a health problem, we didn't ask for it. It just happened to me, right? And that feels very overwhelming and overbearing and can feel depressing in terms of what am I going to do? Can I handle it? Am I going to have to live with this for the rest of my life, and will I be able to function, right? So addressing that, so taking that fear away and the depression away with hope that there is a path forward. People have done it who have been in the same situation as you. Now they can do this. They have been successful in being able to live their life, manage their blood pressure, being able to come out of being an alcoholic. That hope is what having a mentor as an AA program, or having someone you follow in the Higgy program, where they have been able to, they are in the same boat, but they're a few steps ahead of you, and you can see that, and you can see how to get there. It gives you that hope. It gives you the path forward for you to follow.
Yeah, yeah.
I can give you a comment. I think the idea of the game mechanics is not to stay there forever. Idea is to build a sustaining habit so that when the game is over, a habit stays. That's the whole idea behind it. A lot of the mistakes that we've made, we've learned a lot. We've made a lot of these mistakes in the past. The first was goal-based interventions. So when you say lose 10 pounds as a goal, well, when the goal is achieved, becomes your trigger to stop the habit. So we've shown those don't work. So you need to make sure the goals that you're setting and the game mechanics that you're setting are designed on that habit, not on the outcome. Because when the outcome is achieved, it's done. So all our achievements, all our game, initially we used to have all these things, goal-based stuff. If you go to Higgy, there's no goal anymore, because we've seen people who just do goal-based stuff actually stop doing anything after the goal is achieved. Second one is reminders. So everybody pretty much in this industry is using reminders as a medication adherence type of thing. But a lot of research is now showing that reminders are the reason to forget, because now it tells you what it is. So because now you've forgotten about it, there's no habit formation happening anymore. So how do you actually communicate with the patient so it's more of a memory enhancer and remembering this technique rather than telling them something so that they don't have to remember anymore? I mean, how many people remember your phone numbers of friends anymore, right? It's here, so you just dial. You don't even think about it. I mean, we used to remember everybody's phone number. I remember when I was young, I knew everybody's phone number. Now I don't know even my son's phone number. So those are the issues coming. So like, for example, in the reminder scenarios, instead of saying, go take a medication now, did you take your medication today? Or have you taken your medication type of thing? So you make people think that, oh, did I do it or not? So you're trying to reinforce that habit of I need to remember it, rather than telling them, go do this. So even like when we do our push notification stuff and our side, we ask them like, are you going to go do this today? Or something like that, and more of a conversational and more of a making them think of remembering kind of idea. And good thing, these are early stages. We are still learning. We haven't perfected this either. Michael Ferguson from IOGO is probably the first one who's really studied this properly, of idea of remembering aspect of it. So that's the game mechanics aspect of it. It's if all the games mechanics work for everybody, every game would be a blockbuster. The reason it's not, because it's very hard to figure out what the right strategies are. I mean, in Microsoft and Xbox team, we used to constantly talk about what works. There's some strategies that work, but we didn't know what made something viral. You could, no matter what analysis we did, we always got surprised what part of the feature actually got the whole thing going, and the team that were designing wouldn't even think that was the main reason people are engaging with it. Same Pokemon Go, you gave an example. They didn't think it would go viral like this. It was just a little thing that did, and it suddenly took off, and nobody predicted that it will do that, and they were all surprised by it. So it's very hard to build the right game dynamics. You have to really test out your theories and measure and see what is moving the needle in that sign. But I hope I answered your question.
But to the first part about getting more people in, do we have time left, by the way?
We're at time, but if,
we're
if you guys want to
Well,
finish
there's
that
just
up.
I think we have to look for those moments, either on diagnosis, where we're much better about helping people understand. Jesse Grumman used to say, people need to understand that their participation is important, possible, and safe. And I don't think we're covering those things. They don't understand what they can do or that they even can do things. And so they will sometimes just take the medication or sell the medication or because it doesn't really matter to them. But I also think that if we look for those salient moments, we also help people as they're transitioning from hospital to home. So even just if one of your issues were hypertension or whatever, that's always a new opportunity to like help people recognize that like, yeah, you were in for this, but your hypertension is related to that, and that's actually maybe even easier to treat than this other thing. So let's help you figure that out. So I think if you find those moments, you can do that. But I think if you're not giving people that insight that they can do it and how to do it, they can't.
Yep, absolutely.
Can't get there. Yeah.
Did you closing thought there?
Well, to answer your question, the populations I worked with, actually for them, their health was not a priority. They were not thinking about it. So when you think of this population, we want to think of, first of all, who do they listen to, right? So who is that influential figure that they trust and they will listen to and they'll make an effort? And second, what is their priority? So you want to ask them and understand from them what is their priority. So in the example that I shared with you, the priority for the mother was to be able to give a gift to her daughter, but she did not have the money to do so. Right? So she was not doing it to improve her blood pressure, but she was doing it because to her, that was important. And I think it's about understanding that if I want to do something, I want to play with my kids, I want to be able to help them with the homework or whatever that is, how is the current health condition affecting what they want to do today and how it's likely to affect them a few years from now, 5 years from now, 10 years from now, because now you have tied the impact of their health onto what is most important to them. And that's why they would start to care. So that's how you would engage the population that is not engaged in terms of really listening to them and understanding what's important. So you talked about the two extremes. You talked about the one that's totally unmotivated and how do you bring them in, and then the opposite end of the spectrum where you have people who are very motivated and they're so competitive they want to game the system, right? And I think there are few cases I see like that in reality. I wish there were more people like that, but there are not. You see very, very few scenarios in terms of population level of this kind of data. And that's where I think the more mature game principles of progressively making the game harder comes in, and then involving other aspects of the game, as well as removing things that are very obvious that you might be doing without being able to get the reliability of the data, right? So those are things that you can do to address this. But going back to the power of habit, if you've been able to do something consistently for 21 days, you made it a habit, right? So even if they're gaming the system or they're overly competitive, if you have helped somebody to do something for a month, 2 months, 3 months, at the end of the day, they win. It's not about whether they got 50 extra points. So to me, that's still fine.
Well, thanks so much for hanging around for a few extra minutes. I have a few hard copies of the study if you'd like to grab one, if that's something you'd like to read. Otherwise, thanks again for coming.
Thanks, Ryan.